we're going to leave out a lot of the eclectic kind of impingement tests and things like that. But by the end of this, we'll go through several important points in examination. So this is one of the abbreviated ways. I'll get Zach to come and stand in front of me. So I teach the registrars to use a mnemonic when it's shoulder or any examination, and that's HELP, it's H-E-L-P. So say hello to the patient, expose the patient, which we've got patients exposed, but it's very important, especially with shoulder examination, to have a look at the scapula. L is lining, which is always going to be fine in this day and age, and P is position of the patient. Shoulder examination should be done as a standing patient. You see patients look at you surprised when you ask them to stand up, but that's how it's done. So the first thing I look at is from the front. We look at, I'm examining his right shoulder, and we look at the muscle mass on each side, and he's got good lateralization of the deltoid and no obvious abnormalities such as a prominent acromioclavicular joint, even though his right is slightly more prominent than the left. Get you to turn and face the wall there. And this is the best way to look at wasting. And your hands are your best eyes here. So you can look at the front and back, you can feel for the supraspinatus and supraspinatus and infraspinatus fossa. You can feel that even, he hasn't got an injury, but you can feel that the right side is bigger than the left, and that's quite easily seen. If you see someone with big muscle bulk on both sides and they've got no atrophy or muscle wasting, and if it's, for example, a workers' compensation patient, it really brings into question how actually injured they are. However, it's a hard sign that you can't fake, okay? So that's really important. So now turn around and face me, Zach. Whilst you're looking from the back, if you want to do a very detailed examination, you get them to raise their arms out. And if you see jerkiness of the scapula as it moves up, that's scapular dyskinesia or shoulder dyskinesia, and that's also very hard to fake as well. Okay. Now, looking from the front, these are the movements which we're going to do today. Just raise your arm up in the air. So that's forward flexion and then back down, and then abduction there. Okay. And so from here to here is the mid-arc pain, which you can get with pain. Elbows by your side. This is external rotation with your elbows by your side and relax. Now, how far up your back can you go? And I was saying you record that by where the thumb ends up. So that's thumb in the thoracic spine. Now, we've finished a range of motion. We can sort of go into testing the rotator cuff. It's convenient. Bring your hand down to your bottom. Lift your hand away from the bottom. So this is a subscapularis lift-off test, and that's negative in this patient. Now, we still go on to the subscap, hands on your belly at the front, elbows all the way forward. Keep it there strong. Don't let me push you back. So that's nice and strong there. And I'll show you the other group. There's another one. Push hard on the hand, and that's subscap as well. Now, thumbs down like this. This is testing supraspinatus now. So this is probably the most important test that you'll learn today. Two reasons. One of them is an impingement test as well, so it hurts when you turn in and someone's got an impingement. And then secondly, you test your supraspinatus, which is the most commonly effective one. So push up to the ceiling there and push up here, okay, and just relax down there now. External rotation, now push out against me, that's infraspinatus. So we've gone through a patient who's got a full range of motion, but when a patient has a diminished range of motion, for example, with the arm that comes out to, just say he's like this, you have to test passive range of motion. So it's the most painless to test it in external rotation. And so if that's the case and we push here and we can't get it beyond, we'll go into an examination later which we know what that finds. Now, we tested resistance in external rotation, but say the patient can only get the arm out to here. This is one for infraspinatus. Then we bring the patient passively out to here, and then we let go and he will swing back, and it's like a gate shutting. That is called the lag sign, and that's weakness of the infraspinatus. But we can passively get him up beyond that, so that means he hasn't got arthritis and he hasn't got a frozen shoulder, okay? And now we've gone into look, move, feel, but you can do look, feel, move either way. So with palpation, the main things that are tended to palpate are three things. So it's tenderness at the acromioclavicular joint here, tenderness here at the supraspinatus insertion, and there's the bursa that's painful there as well, and tenderness to palpate at the biceps tendon. Now the special test we've done, the infraspinatus, the impingement test, which is the most commonly done one, is Hawkins impingement test. There's another impingement test where you stabilize called NIRS, the scapula, and see whether that impinges, but you don't have to do all of these. And finally, to test the acromioclavicular joint, you say, do you feel pain at the front here when I do this? So it's a scarf test or cross-arm adduction. And the other one is grab this, pull as hard as you can, and do you feel pain up there? And so that's it there. And if we have time, we can go through the stabilization, dislocation examination. So thank you, Zach. So now I'd like someone to volunteer to examine Sean. Anybody? Yeah, Paul, excellent.
Can I reach up to you?
Yeah.
Close to meet you.
Okay.
So great. So hello, he's exposed.
Hello.
Yep. And the position is standing. So you've already got a great start there.
Okay, that's
Ali's
Right, so pretty symmetrical to now.
Yes, it's pretty symmetrical. Excellent.
Face the other way. Yeah. Just normal shoulders. That's it. Can't see on top, but it looks pretty symmetrical to me. No one around. Okay.
Clearly,
Should
there's a
be
lot of
that
deformity,
disconnect.
but go on.
Okay. Now,
That's good.
look, feel, move.
No, you can move. Yes, excellent.
Shall we do the? What did we first?
Get him to do it actively
Yes.
first. Yep.
First, forward
Forward flexion.
forward
Excellent.
flexion.
So
Backward
he's-
flexion.
Is it better one at a time?
Yeah. Do just
One at a time.
concentrate on his
The
right.
right. Forward flexion. Backward flexion.
So it's
Extension.
just call what you see there, Paul. So he's actually showing you that he's got mid-arc pain there, and he can't get all the full range. So you're not going through the motions. You're trying to pick up.
You're diseased. Then.
He's diseased.
Okay.
Clearly, he's
Right,
diseased.
right, you're a real thing.
I am.
Okay, so forward flexion. Is that the maximum you can do? Okay, limitation.
Yeah.
90 degrees.
Yeah.
Now, extension. Extension, backwards. Okay.
Yeah.
Pain there?
A little bit.
More there. Okay. Abduction. Limitation of
Yeah,
abduction.
limitation.
Yeah.
But he can still, you know,
Still
he can
do
still
it.
bring
What's
it
your-
up.
bring it up above your head?
You can still bring it up above his head pretty well. Yeah.
But is he
So that's
using,
the-
is he false? Is he using
Yeah.
the shoulder?
But still, so what you're calling there is mid-arc pain,
Okay, yeah.
and then that's it.
Yeah.
Okay. Any other?
Adduction.
Abduction?
Adduction.
The other way.
Patients
Want
don't
that
know
way?
what that is.
No.
You want this way?
No.
Abduction.
Your arm straight. Yeah. Across your chest.
Abduction. You want that way?
Yeah.
Yeah.
He's not a doctor.
Yeah.
Okay. All
All
right.
right. Okay. Yeah.
In and out. Okay.
All right. Good
Now,
stuff.
What do we do now? Bend your elbows. Okay. This is the affected one.
Yes.
Move it out.
Excellent.
One at a time.
So is there any diminished range? No,
it seems
good.
to
So
be.
it looks
Okay.
good. Yep. That's excellent. So in summary, he's got some restrictions,
Few
probably about
shoulder.
30 to 40 degrees of end range. He's got mid-arc mid-arc pain. Anything else?
You
you'd
look
like to-
like one of the doctors sitting there with a computer.
I was writing
I thought you.
notes.
I thought you were
I was
one of the
writing lots
doctors.
of notes.
there.
No.
I apologise.
Yeah.
Right. What do we do now?
That's great. Look, move, feel.
Move,
Did you
feel.
want to palpate across there?
Okay.
Yes. So just watch his face. He's
Tender?
got tenderness at the AC joint and a little bit at the supraspinatus insertion. Okay.
Supraspinatus tendon.
So very, very common to do that. Okay.
Yes.
Yep. Yep. Okay, good stuff. And now special tests.
Okay. These are very complicated.
Yeah, that's
Where
okay.
do we
That's
start
okay. So this is one where when you turn it down, the supraspinatus, he might have pain, and then pain on resisting.
Supraspinatus.
This is
Okay, so
supraspinatus. Yeah. So this is testing for supraspinatus strength and also pain.
Was limitation
Yeah.
of movement, obviously.
Yes. Yeah.
And pain when you're moving it out.
So
You have
Yeah.
to-
So what you're testing now is the power of the different movements, but you can do special tests as well. So if you're testing power with this respect, this is for supraspinatus. You're asking him to push up to the ceiling, push up, push up, push up, and you can see that is weak there as well. And with the elbows by your side, this is testing infraspinatus, push out. Yeah. And if he's actually weak, he might only come out to here. And this is the one where you bring it beyond and then let it go, and then it swings back. But both supraspinatus and infraspinatus are
Limited.
but supraspinatus is limited. Now, going on to the special test, probably the good one to do, he's got acromioclavicular joint tenderness and also
rotator.
yes,
Rotator.
yes. So you can test this one. So thumbs out here. And would you like to push up?
So one arm at
Yeah,
a time. We'll
yeah.
do my left arm first.
Yeah. So it's got good strength there and no pain. And
Pain there?
so he's got pain and diminishment. And the impingement test, the Hawkins impingement test. That's good here. Yes, exactly. So you go that there, and then you can see he's wincing there.
Good, sir. Obviously, the
Yeah.
dog is different.
Yep. Okay. And now, in terms of the AC joint, there's cross-arm adduction. So just whether he's got pain with the arm across the top there. Yeah. So whether he's got pain when you're pushing it across there. And axial compression is when you hold it here and you pull it there and see where and ask him whether it hurts.
Pain there.
Okay. Yeah, and he's got pain there. So this is a very common finding, especially in even a young patient who does labour-intensive work. So we've got a diminished range of motion, and sometimes end-range pain is the AC joint. We've got mid-arc pain, we've got weakness and provocation testing of the supraspinatus. So he's got impingement, possibly a partial tear, possibly a full thickness tear, and also acromioclavicular joint pathology. That's it.
You
Well
need
done.
surgery.
Yeah. Well, maybe. So would someone like to examine Zach now? We won't get his mum to do it.
With your induction, I was like, yeah. I'm sorry. I was like, oh, okay. Sorry.
Anyone want to have a go at that? Yeah, go for it. Yeah, I'll talk you through it anyway. If there's any stop.
No, there's nothing.
Supposed to say hello?
Yes, excellent. Hello, he's exposed and he's
Yeah,
got the
good
right
lighting,
position.
right position, having a look at any muscle atrophy. If you can just turn around and
That's
face
great.
the
So
wall there.
see how she's controlling, this is great, she's controlling the patient, she's not moving around the patient, that's good.
So having a look at any atrophy there. So I'm just going to palpate the muscle.
So the supraspinatus is good.
Is there any tenderness there?
A little bit on the right,
A little bit on somewhere here.
just generally.
Yeah, generally. Okay, just turn around.
Okay, good stuff. So
So
looking at his right
move.
shoulder, yeah.
Yeah, so you're moving. So if you can, so I'm just going to examine this one first. If you can move your arm right in front of you, straight up. So there's this limitation in movement and pain. If you can move your arm that way.
So it's good to get in the habit of, that's great. Just call some degrees out, okay? Because you're going to document in his notes, and then you're probably going to say, that's probably 30 or 40 degrees, isn't it? So if that's 90, that's 45 millimeters, that's probably about 30 degrees. And
Okay.
abduction to the side is the
Yeah,
same, isn't it?
so yeah, that's about
What's some other
30.
movements?
If you can extend with your arms back, that's about 20 degrees extend, 20, 30 degrees extension.
Excellent.
Then we're looking at rotation. If you can bring your arms up this way and turn around here. That's restriction. That's
So how do we
about a-
check internal rotation usually? It's arm behind the, that's external
Oh.
rotation, it's arm behind the back, isn't it?
Right,
Yep,
okay.
so do you want to
Yep,
try
so we
ask
can-
him to do that?
Yep, if you can bring your thumb right up, there's limitation there, only up to, how do you record
Would you
that?
be looking
Yes.
at
So you record that
Record
thigh,
it
where
like-
does the thumb end up? So if the thumb ends up at the thigh, that's internal rotation of the thigh, to the buttock, lumbar spine, thoracic spine,
Right.
beyond.
And the,
Okay.
so-
the patient should be facing away from you?
Yeah,
and
so
Right.
you'll be able to see that. a bit
So
better.
you
So he's
can,
got, where is that up to?
Up to the bottom.
And then how do you know, what if he's always like that? How do you know? Try the other side.
Oh,
Try
okay.
Yeah.
All right, now use
Yeah.
this hand.
Okay.
Yeah.
Excellent. Okay.
Okay.
So you're still testing range of motion. You missed out external rotation. You want to check that. That's this
Yeah.
one here.
Okay. So I'm just going to move your arm sideways.
Get him stop. Get him to do it actively first.
Right,
Okay.
you can
Yeah.
move your arms.
Do you always do active?
Yeah. Do active first, and then.
Okay, so that's about a.
So how do you know it's not?
30 degree.
How do you know what's that like compared
We'll
to the other
check
side?
the other
Okay.
side. Yeah, so you can move that. Yeah.
Yeah.
So that's,
Okay.
Yeah.
So this is a great one to really demonstrate active versus passive range of motion, okay?
Yeah.
So he's showing you restricted active range of motion. Do you want to try his passive range of motion beyond
Okay. So we're just going to move your arm sideways.
So it's limited.
So it's limited as well.
Yeah.
Yeah, to about
Okay.
30 degrees.
So you're barely able to push it. What does it mean when you've got restricted active and passive range of motion? What diagnoses could it be? And this is the best one to check that. With forward flexion and all this sort of stuff, it's quite difficult to test it without hurting the patient, but
Yeah.
this is quite a painless, but really truly shows a contracture of the...
Yeah. Frozen shoulder.
Yes, and what's the other thing? Imagine it was 50 years older.
Arthritis.
Exactly. How do you tell the difference?
Okay.
Do a plain X-ray.
Right.
That's all it is. So global restriction and range of motion can be frozen shoulder arthritis. To diagnose either one of those is to do a plain X-ray
Okay.
to do it. So that's it. That's it.
Thank you.
So, and I don't think you can, so you've shown the global restriction, you've probably seen it for an X-ray and that's normal. I don't think I've seen a frozen shoulder without the patient having some impingement signs. So don't get fooled by, oh, it's only impingement, let's inject the subacromial space, because the global restriction in the range of motion plus impingement is still frozen shoulder because they get inflammation on top of the cuff and below the cuff as well, all right? And you can inject the subacromial space. They'll take a bit of the pain away, but they'll still come back to you. And it's crazy pain, so they say this is pain and stiffness, sometimes there's burning, there's tingling, there's nothing like I've ever felt before, and it's getting worse and worse. The treatment for that is an injection of the glenohumeral joint with local anaesthetic and cortisone, either done with ultrasound or CT scan guidance. You can spread that to, 3 months apart or 6 weeks apart, depending. And just gentle physiotherapy. They don't need any manipulative physiotherapy. In fact, if that makes the pain worse, it's diagnostic of frozen shoulder almost, okay? So we'll just now move on. I'll show you guys how it's a bit left field, but the examination for instability. So someone's had a dislocation, they come to you in the clinic. The first thing you do is to check for a few things, which is slightly different from your normal shoulder examination. So we're looking here, can you feel me touching on both sides? We're checking for axillary nerve palsy, which often gets injured. Now we're going to check for ligamentous laxity, because as I mentioned, that decreases the chances of a shoulder stabilization working, but also if you have ligamentous laxity, you've got more chance of having a posterior dislocation or multi-directional instability. So this is something you can do for all of your patients where you're checking from that. So the first one is to get your thumb and put on your forearm. Can everyone do that here? You can do that. You can't.
No.
You can't. Yeah. So I think Sean and I are the only ones who've got ligamentous instability in this group. And then this one is any of your fingers to bend it back. If you can get it parallel to your forearm,
No.
like that, so you've got ligamentous instability. Next one is you move to hyperextension of the elbows, and you see that is hyperextended by 10 degrees. Now the next one is hyperextension of the knee, and that's popping out there. He's got that, and then bending your foot all the way back, and that's a lot. So that's often, so he's got ligamentous instability. So you need to get,
unstable.
You need 3 out of 5 of those to meet the Wynne-Davis criteria. This one you can do a little finger, and if it's parallel to your forearm, yeah.
No way.
That's
good.
so. And it's quite a common thing.
Do you
Like
charge for that?
if some people are ligamentously unstable, they just give up and don't do any sport. But Sean is slightly different. He's need to overcome that. You need to be 1 minute. You need to be really strong to overcome ligamentous instability. Now I'll quickly go through. Take a seat on the side of the bed here. So now I'm checking for the sulcus sign and seeing whether this, like you see a little dimple there, and he hasn't got that. Lie back flat on the bed. So we're coming around here, and so we're talking about traumatic anterior shoulder dislocation. So we're putting the arm out here, and we're taking out here, and then he feels apprehension there, and you tell the patient, I don't want to dislocate, you tell me when you feel. So he feels apprehension, you go, if I push on the front, does it make it feel better? And the pain will actually go away. Then you bring it back, and then it comes back there. And then you can then test a posterior labrum, like this, and then relax your arm down on the side, and you can check for anterior and posterior draw. So that's anterior draw and posterior draw is stable in him, so he's got a stable shoulder. So I think the thing that you get out of that is the ligamentous instability, and that would be in keeping with the young child who pops the shoulder out, who can't really rehab, can't really get strong, and you can kind of give them a reason why, but still it's rehab until it fails and they've got pain. Any questions about shoulder examination? Good stuff. I think we've got one more group.